I'd like to first welcome everyone. Thank you for attending our virtual health talk series. We used to come out to your communities and do live talks, but in this new age, we've become even more personal, coming to your offices, living rooms, and so forth through a virtual platform. Giving you the opportunity to still get the health information you need at this time. Today we have a great talk with Dr. Joseph Wells Henderson. He is from the Division of Female and Pelvic Medicine and Reconstructive Surgery at the Department of Urology. He can be seen at University Hospitals Bedford and Richmond Medical Center, and also has a location in Cuyahoga Falls. Just so you know, a little housekeeping, you'll see a Q&A function at the bottom of your screen. This is how you can submit questions for Dr. Henderson. We'll take the questions at the end of the talk, but feel free to submit them along the way. Some of those questions may get answered within the presentation, and then we can also address those unanswered questions at the end. There is a button when you submit your question, an anonymous button, so your name will not appear in the questions if you so wish. And then just so everyone knows, this is being recorded, and we will send out an email after the event. You'll probably receive it early next week, perhaps late this week, with the link to the recorded presentation and more information on how to contact Dr. Henderson. So without further ado, we'll hand it off to Dr. Henderson now.
Perfect. Nice to see all of you virtually. I'm Dr. Henderson. Again, I work at University Hospitals Bedford, Richmond Medical Center, and also see patients at Cuyahoga Falls. Today's presentation is titled Urinary Incontinence Myths and Solutions. And this is, as I am a female pelvic medicine and reconstructive surgery specialist, this is for our female patients out there. I have no disclosures. Who am I? I did college in Boston and then went to medical school in Philadelphia and then trained out west in Utah, did my fellowship here at University Hospitals and Metro Health, and have been practicing within the Department of Urology and OBGYN for the last 3 years. Live in Shaker and again, see patients Bedford, Richmond, and Cuyahoga, and then operate at Bedford and Ahuja and Richmond. But today's conversation really is about urine, urination specifically, and to pee or not to pee. You should be able to choose. So we're going to talk about a couple myths and hopefully answer questions along the way that you may have. First is, I was born in a diaper and I'm going to die in a diaper. Second being, after having a child, anytime you jump, laugh, cough, sneeze, it means that you'll be wet, and that's a normal part of that. And thirdly, if you walk into a store, you go outside, of course it's totally normal to know where every bathroom is. Now, the types of urinary incontinence, and of course urinary incontinence means losing urine when you don't want to lose urine, typically revolves around two specific kinds. One is urgency. That means that you have that feeling of needing to go to the bathroom and you can't make it, or you can just make it. There's stress incontinence, meaning you laugh, you cough, you sneeze, you stress, and you leak urine. Then there's a mixed, where people have both that laughing, coughing, and sneezing, leaking, as well as that urgency. And finally, there's overflow, and there are other varieties of incontinence that we won't really touch on here that are less common. Now, urinary incontinence is incredibly common among female patients, unfortunately. It is a significant burden to sleep, to falling, sexual dysfunction, happiness, you name it. Urinary incontinence can affect quality of life. These are old numbers here in terms of the average per year cost of incontinence. It's now about twice that. But urinary incontinence is something that is debilitating and extremely expensive. There are more adult diapers sold in the United States than pediatric diapers, just to kind of put it in perspective. It's very common. So all comers, urinary incontinence is between 30 and 40%. Now, as patients age, that prevalence, the number of people within that group, gets more common. So specifically with urge incontinence, by the age of 50 to 60, it's about 40%. It goes to 50 and 60 and 70. Again, it is not a normal part of aging, but age is a risk factor. Now, what are some of the risk factors besides aging? Now, aging itself has issues with compliance, meaning how stretchable the bladder is as one ages. It has to do with changes in the neurology of the bladder and the specific muscle neurons of the bladder. And the bladder becomes less responsive as people age. There's also an estrogen component. We know that if we give back vaginal estrogen, that patients do better from a urinary urgency standpoint. Finally, other issues with the pelvic floor, whether a patient has stress incontinence, whether they have pain, whether they have prolapse, those sorts of issues can increase your risk of having urinary urgency complaints. So with stress incontinence, that's the laughing, coughing, and sneezing, we also see age as a risk factor. Parity is the fancy word for the number of times one's been pregnant. If you've had a vaginal delivery, that also increases your risk. Weight. So a weight above or obesity is an independent risk factor for stress incontinence. Similarly, losing weight also significantly can improve stress incontinence complaints. Diabetes and patients who are on hormone replacement therapy sometimes have worsening stress incontinence. We'll kind of touch on the reason why here in a little bit, because I just said earlier that adding back estrogen for urgency sometimes helps, but here we are, systemic estrogen actually making stress incontinence worse. There's a family history, there's a familial component to this, and race. Whites have this more than Hispanics, have it more than blacks and African Americans, as well as Asians. So try not to become as active as your bladder, because today we're going to talk about ways that we can try and manage this. So how do we determine what's going on? The basic evaluation is by far the most important piece of this. And there are really three components. There's the history, coming in and seeing me or one of my colleagues. There's the actual physical exam. And then there's some of the basic lab values that we can get while we're in the office. Voiding diarrhea is something that we may send you home with, and we'll talk about that in just a sec. So, history. A lot of questions here, but these are important questions to determine what kind of incontinence that you are complaining of. When do you leak? How do you leak? What's it associated with? What are your goals of therapy? What kind of things are you doing? Sometimes it's as simple as cutting back on some of the fluids that you're drinking. Sometimes it's as simple as changing the way that you drink those fluids. But we need to ask all of these kinds of questions in order to get a better idea of what's going wrong, so that we have a better idea of what we can do to help with this. Along with that history come medications, because there are a number of medications that can worsen incontinence. Diuretics don't make the bladder any more sensitive, but diuretics make more urine. You make more urine, you're going to pee more often. Narcotics, pain medications, antihistamines, all of these can affect the bladder in different ways and cause different complications with the way that the bladder is behaving. The other part of this, of course, is the physical exam, looking at the support of the pelvic floor, looking to see if there's any kind of prolapse. People will talk about my bladder's dropped. It's really not the bladder, it's the vaginal wall has dropped. The bladder is kind of an innocent bystander and is along for the ride. Is there a painful bladder on the exam? Do the muscles of the pelvic floor, are they weak or are they painful? Are there any masses? Is there significant atrophy, meaning that those tissues of the vagina haven't seen estrogen for a number of years? So all of these are important parts of that basic evaluation, including the urinalysis. So we dip that urine, make sure that we're not missing any infection, bleeding, etc. And a post-void residual. When you go to the bathroom, is your bladder really empty? And finally, we sometimes do something called a uroflow, which looks at how quickly your bladder empties. Now, avoiding diarrhea, which I touched on a little bit before, is something that allows you and me to get a better idea of how that bladder is behaving and misbehaving at home. It's very simple. Over 3 days, we look at ins and we look at outs. How much and how and when are you drinking and what? And how often are you urinating and how much is coming out, to determine what kinds of things we need to do in order to improve your incontinence complaints. Now, beyond the basic evaluation, we may move on to a cystoscopy. That's a small fiber optic camera that can be placed in the bladder to look to make sure we're not missing any kind of cancers, abnormalities, prior surgical issues, etc. We may also go on to imaging, doing a fancy X-ray, a CT scan, looking at the kidneys, the tubes from the kidneys to the bladder, determining whether there's a component of kidney stones that may be causing urgency or spasticity. Are there abnormalities, diverticula, etc., that may be causing these issues? Urodynamics is a fancy bladder test that's a way of looking to see how well the bladder functions. How does the bladder fill? How does the bladder empty? And how are your symptoms associated with that? So in terms of your urge incontinence, that's the I gotta go, I gotta go, I gotta go. First line therapies are very basic. Looking at how and when fluids are going in and how and when the fluids are coming out. So time voiding, getting you to the bathroom in a timely manner, and watching again what those fluids are that you're drinking. We also talk about bladder training and pelvic floor physical therapy. Within the American Physical Therapy Association, and the email address is written on the bottom here, there's a group of women who have been specially accredited to do what's called pelvic floor physical therapy. And this is a way of strengthening that pelvic floor, getting rid of pain and improving how dynamic that pelvic floor is, to holding on to the urine and then relaxing to let go of that urine when you decide. Second line therapies for the treatment of urge incontinence involve medications. And you may have heard of things like oxybutynin, Toviaz, trospium, Vesicare, etc. These are medications that are called antimuscarinics. There's one medication that's called a beta-3 agonist, and that's called Myrbetriq, which you've probably seen advertised on television. Now, these medications have their own side effects. First and foremost, medications are there for one purpose and one purpose only, to improve your quality of life. So if these medications have bothersome side effects, we stop them. We look for an alternate therapy that's not going to give you the bothersome side effects. And the main side effects are, again, dry mouth and constipation. And you'll see that it's anywhere between about 10 to 20% in all comers. But that doesn't mean that you'd be affected by that. We have to try it, see if you have a benefit. And if you do, it's a safe medication to kind of use forever, or we simply stop it and move on. The beta-3 agonist, or that mirabegron, or the Myrbetriq, is very nice in that it typically doesn't have issues with dry mouth or constipation, but it can elevate blood pressures, which is why we cannot use this medication in patients who have uncontrolled high blood pressure. That being said, we can use it in patients who have controlled blood pressure. We just watch the blood pressures to make sure that we're not causing any trouble. Now, third line therapies, there are 3 FDA-approved third line therapies. Botox to the bladder, there's something called PTNS, or peripheral tibial nerve stimulation, and finally, sacroneuromodulation. Botox, injected directly into the bladder. PTNS is like a fancy acupuncture, and we'll talk about it in a second. And then the sacral neuromodulation is it's almost like a TENS unit and a pacemaker for the bladder to calm it down. So Botox, through a small cystoscope, that's that little fiber optic camera in the bladder, injected directly into the wall of the bladder. It can be done in the office, it can be done under light sedation in the operating room, and the procedure takes about 2 minutes. You notice benefits within 7 to 10 days, and those benefits should last anywhere between 3 to 18 months. Most people have about 6 months. Now, it has 2 potential side effects. One is urinary retention, meaning that we need to actually drain the bladder because it works too well, almost. And that's something that requires a catheter, something that you can do yourself or wear a catheter. Now, typically that doesn't last more than about 4 to 6 weeks. And then the bladder finds its happy place. But the other risk associated with Botox is the risk of a urinary tract infection. And if that were to happen, we simply treat it. Now, this is just a slight graph showing you that with 1 dose of Botox, it has the same efficacy, meaning that it drops those urinary urgency incontinence episodes by about 3 to 4 times a day, okay, which is similar to a pill. But instead of having to take a pill every day with potential side effects of dry mouth and constipation, this is an effect that, looking at this little chart here, lasts at least 6 months, which is great. PT&S is a wonderful option because it really doesn't have any side effects. No dry mouth, no constipation. The only risk really is some bruising at the ankle site. So on the inside of your ankle, there's that little bone. Right behind that bone is the tibial nerve. We stimulate that with this very small, you'll see that little acupuncture needle there, stimulate that with a little fancy electronic box. The only issue with this therapy is it's a time commitment. You need to come in once a week for 30 minutes. You come, bring a book, read a book, get this nerve stimulated, and you go home after 30 minutes. But you have to do it for 12 sessions. And then typically after that 12th session, you come back every 4 weeks to 12 weeks for a 30-minute little top-up. But again, it's a very safe option. Finally, sacral neuromodulation, and there are 2 products on the market now, one called InterStim, one called Axonics, and it is a little battery that's placed right on your bottom, and that battery is attached to this very thin, fine wire that stimulates the sacral 3 nerve root that goes to the bladder that's causing the bladder to be overactive. This little wire massages that nerve root and decreases that sense of urgency. Now, this is something that is called a staged procedure. Wire is placed, external battery is worn for 2 weeks while we see if this works. And at the end of those 2 weeks, one of 2 things happen. You say this really helps, at which time a little battery is placed under the skin, and that battery will last usually up to 5 years, or it doesn't work after those 2 weeks and everything just gets removed. But it has wonderful efficacy. It's something that if it works, you're on your own for years, which is wonderful. And this is kind of what it looks like. It's this little pacemaker that goes under the skin and this very thin wire that again stimulates that little nerve root. So let's move on to stress incontinence. With stress incontinence, there are really 3 options. There's lifestyle changes, losing weight, improving fluid management strategies, pelvic floor physical therapy. Then there's, in terms of interventions, a pessary or surgery. And we're going to touch on all of these here. So lifestyle modification, like I said, losing between 5 and 10% of your body weight can improve symptoms by 50%. Quitting smoking, working on chronic cough treatment, all of these can help with stress incontinence. Similarly, vaginal estrogen has been shown to have some benefit to the stress incontinence and is a very safe option as it is not absorbed systemically. It does not cause breast cancer. It is something that we safely use in our breast cancer survivors and patients actively being treated for breast cancer. The other option is, like we talked about, this pelvic floor physical therapy, which can also help with the urgency. These are some little pictures of vaginal weights and what we call biofeedback. And with a pelvic floor physical therapist, they can help patients work on the strength and a guarding reflex of that pelvic floor as one coughs or laughs or sneezes, bounces on the trampoline, etc. The next option is what we call a pessary. And this is an insert that's made out of a latex-free material, silicone, that gets placed in the vagina and acts as a little speed bump underneath that urethra. This is the bladder, this is the urethra. It supports that urethra because stress incontinence involves an anatomic change. When you laugh and you cough, the urethra is not supported and doesn't kink. So a speed bump here can help, okay? Now, this is something that's placed in the office. It takes a minute, to place, and usually patients will go home for a week to see if this is something that will help. It can be removed at any time. There are really no risks associated with it. This is what they look like. Again, it has that little speed bump that goes underneath that urethra, and again is fitted in the office here. The definitive option for stress incontinence is a surgical one. The American College of Obstetrics and Gynecology, the American Urologic Association both agree that a sling is the best option for curing stress urinary incontinence. Now, this is not the vaginal mesh that the FDA pulled off the market about 1.5 years, 2 years ago. This is something totally different. We've been using these slings since 1995, 1996. So we have about 25 really good years of data on this. And what we know is that these slings are about 90% effective at curing stress incontinence for your lifetime. There are two options, something called a TVT or a TOT. And they're very similar, but they have some very slight differences between them that are highlighted here. But fundamentally, these are very successful, safe options for definitive surgery of stress incontinence. Now, the risk, of course, is that this is a foreign material, that it may rub through the vagina, and of course, it may not work in about 10 to 15% of people. This is what they look like. The TVT is on the left-hand side of your screen, and the TOT is on the right-hand side of the screen. Just demonstrates where those little slings are going to, again, support that urethra as you laugh and you cough and you sneeze. There's also the ability to harvest some fascia from your own, from your abdomen is usually where I use it from. And that fascia, which is a very strong piece of material, can be used to go under that urethra as well. Now, no complications from a foreign material because it's your own, but as you read here, but there are higher rates of retention. It's a more involved surgery. Instead of being a 30-minute procedure, this is usually a 2 or 3 hour procedure that requires a night in the hospital and an incision on the abdomen. Again, great option, but one that's just a little bit more complicated in patients, and one that we typically use in patients that have failed a sling or have other complicated pelvic floor disorders that won't allow for a sling to be used. There are things called bulking agents that you may read about online. These are injected with that cystoscope either in the office or under late sedation in the operating room. And what it does is they act to coaptate or make that urethra that you pee out of a smaller diameter. Now, there are a bunch of different products, but the problem is the cure rates don't last very long. There is a new product that is coming on the market that's been used in Europe successfully for the last 10 years, but still these bulking agents don't seem to have the same efficacy. They don't work as well for as long as those mid-urethral slings. That's all I have for urinary incontinence. I'm very happy to answer any questions that you may have. For any kind of appointments or questions or concerns, you can follow up with me at University Hospital's Bedford Medical Center, Richmond, or I'm once a month for now and likely increasing this at Cuyahoga Falls as well.
Thank you very much, Dr. Henderson. That was a great presentation. And we would now begin the Q&A section. In the bottom of your screen, you see the Q&A function. Feel free to submit your questions. You can submit anonymously. There is a button to do that. So if you'll go ahead and start. We do have a question that came in prior to the talk, and this person asks that they're a 66-year-old woman and she's curious on how urinary incontinence can be treated for someone her age. She claims that she has no UTI or any infection, but she's having issues, especially in the morning. She was recently diagnosed with a kidney stone, and on that CT also was told that she has a thickening of the bladder. So I want to know if those issues are related to incontinence.
Sure. So 66-year-olds that's the sweet spot of urinary incontinence, unfortunately. So absolutely all of the therapies that we talked about during this talk are options. When it comes to urinary urgency, especially if it's kind of an acute onset and you have imaging that shows a stone, very likely it's associated with that stone. A stone is very sharp. Consider it a stone that can be bouncing around your bladder and those tubes that go from your kidneys into the bladder, which causes irritation. Irritation causes the bladder to spasm. When it comes to thickening of the urinary wall, that's something that is sometimes an artifact of the scan that can have to do with the bladder just not being distended during the imaging of the scan. But if there are concerns with a history of smoking or a history of bladder cancer, one of the easiest things we do is, like we talked about earlier, placing that little camera inside the bladder. But when it comes to urgency, those three options, that American Urologic Association's care pathway, the first, second, and third line options are great options really at any age. I hope that answers your question.
Great. Our next person asks, I've heard that some of the medications increase the risk of dementia. Is this true?
Great question. So these medications are called anticholinergics. And the problem with anticholinergics is, again, like mentioned before, it has these potential side effects. The main ones, again, are the constipation and the dry mouth. Now, the issue with the anticholinergics, like this person commented, is there's concerns about dementia. The problem right now is we do not have good data to support that. There have been two very large retrospective, meaning we've looked back on patients, and they've found, or they believe they found, a very weak association between the use of these medications and dementia. It's one of these chicken or the eggs. The problem is that anyone who has early onset dementia, cognitive effects, or cognitive deficits, they are all at increased risk of developing lower urinary tract symptoms. So is it the medication that's causing the dementia, or is it the dementia causing the medication? What I can say is that there's one medication out there within the anticholinergic family called trospium. And the way that it's packaged is it is not supposed to cross the blood-brain barrier and cause cognitive changes. The truth is, right now, there are weak recommendations that we start these medications because, unfortunately, the insurance companies almost across the board require us to try one of these anticholinergics first. But I'm here to reassure that these medications do appear to be safe, and the association with these medications and dementia it's a very slight one and very, very weak one at this point. But the truth is that we have that other medication, that beta-3 agonist, this Myrbetriq. It was brought onto the market in 2012. It'll be coming off of patent, I believe, later this year. At which point, it will become a lot more affordable for a lot more people, because unfortunately a lot of insurance plans don't cover it unless you fail these other anticholinergics. But that medication has no cognitive side effects or risk of cognitive decline, anything like that. So there are medications that appear to be safe, but it's a great question. We really don't know about the dementia association, but it doesn't appear to be a strong one at the very least, okay?
Sure. Our next question is, if someone had endometrial cancer that was estrogen receptive, can they do estrogen externally for stress incontinence?
Great question. So typically speaking, if there is a pelvic cancer that is estrogen receptor positive, we typically recommend not utilizing vaginal estrogen therapy. Now, if it's a cancer that was diagnosed, treated many years ago, and you've been disease-free for a number of years, then typically what I do is I talk to the gynecological oncologists and weigh those risks with those benefits. What we know is that patients who have breast cancer history or are actively being treated for breast cancer, that the estrogen that is absorbed systemically from the vagina is non-quantifiable, that there is no increased risk of clot, of breast cancer. But typically speaking, when it comes to those estrogen receptor positive cancers of the pelvis, we try not to use the vaginal estrogen if we can.
Our next question is, if I have stress incontinence, I'm not overweight or have any lifestyle changes, I've seen pelvic therapy, is surgery my last resort?
So again, there's the pessary option, which is something that you simply we have to try it to see if it's going to work, and you have to be comfortable with something kind of being inside of you. Now, the wonderful thing about the pessary is it is something that you can be as active with it as you want, or inactive as you want. And what I mean by that is once a pessary is placed, it can stay in place for up to 4 to 5 months. And every 4 to 5 months, you come see your physician, the pessary is removed and cleaned, a quick vaginal exam, and replaced. Now, when it comes to these stress urinary incontinence pessaries, these are ones that are more easily managed even at home. And I have patients who will place the pessary ring when they go for a run, because that's when these symptoms are the worst, take it out at the end of the run, and then go about their business, and they only use it as necessary. Another option, which is kind of one option that you can try, is actually trying a tampon. And if you place a tampon vaginally, sometimes that tampon can give you just enough support of that urethra to help with that incontinence. So if you've done the pelvic floor physical therapy, you've done all the weight loss, you've done the fluid management, the 2 next best options are pessary or the surgery.
Our next question is, if you could tell us the average cost of the stress incontinence surgery, and do insurance companies usually cover it?
So these are elective procedures, meaning you get to elect to do them, but they're covered by your insurance. I don't know what co-pays are. I don't know, what hospital systems your insurance can cover, but these are medically indicated but elective surgeries. So for example, if you're having your knee replaced, this is the exact same thing when it comes to the payment by the insurance companies. In terms of the surgery itself is a same-day surgery for the stress urinary incontinence. You come in the morning, the surgery takes about 30 minutes. You have about an hour to 2 hours in the recovery room. We make sure that you can empty your bladder before going home, and you go home. It's the easiest thing is to contact your insurance company to see what your copay is with the surgery. But no, this is absolutely medically indicated and covered. All of these. So the stress incontinence, as well as the sacral neuromodulation, the PTNS, the Botox, these are all FDA approved, medically indicated, but elective procedures.
Our next person asked, she'd like to know what happens when you have a bladder that has fallen.
So that's called prolapse. And again, I'm a fan of the bladder. I hate it when people blame the poor bladder for something that's not its fault. So when it comes to prolapse, the vagina has 3 different areas. We talk about the front wall where the bladder sits. There's the top where the uterus is or should be after a hysterectomy, and the back wall where the rectum is. Now, the walls of the vagina can weaken. Just like people have hernias of their abdomen, you can have a hernia of the vaginal vault. So the front wall can drop, the top can drop, the back wall can drop. Unfortunately, a lot of physicians just kind of globally talk about prolapse being a fallen bladder when it isn't, because it's the wall of the vagina, and it could be the back wall of the vagina, it could be the top of the vagina. But if it does involve the front wall of the vagina, the bladder sits on that front wall, and as the wall drops, the bladder drops with it. So prolapse is something that is a different conversation and a different talk. But prolapse can, again, interfere with urinary incontinence and can cause urinary incontinence. It can also kind of hide urinary incontinence as well. But it's a different conversation than the one we're having today.
Okay, next one, you may need to help me with the pronunciation, but do you deal with lichen sclerosus?
Lichen sclerosus. So lichen sclerosus is something that happens in our postmenopausal women, and it's considered to be almost an autoimmune disease of the vaginal tissues, where there's an autoimmune response that can cause scarring, irritation, inflammation, itching. It is typically treated with vaginal steroid cream as well as vaginal estrogen therapy. But this is something that I absolutely deal with. In very advanced and complicated cases, we have to get our dermatology colleagues involved. But it's something that's typically treated with what we call high potency topical steroids and estrogen cream.
Our next person asks, how successful is self-exercise of pelvic floor muscles, and do you need PT supervision?
So that's a great question. Typically speaking, if patients are asked to contract their pelvic floor like they're stopping a stream of urine, about 70% of people can do it right, and 30% can't. So the idea of doing your own home pelvic floor physical therapy, we don't have really good data to support it. It doesn't appear that it's going to hurt, but typically speaking, having one of these pelvic floor physical therapists guide that therapy is the best option. So pelvic floor physical therapy is not your typical physical therapy, meaning that these women will see you once a week or once every 2 weeks for a session to go through what's getting better, what's not changing, what needs to be worked on, so that you go home and over that next week or 2 weeks, you're doing those core exercises, those stretches, those strengthening techniques. But typically speaking, it does help to have some guidance. And in this COVID epidemic era, the pelvic floor physical therapists are beginning to open up. It is not a group activity, as you can imagine. So it's a one-on-one, masks, gloves, and it's something that, again, you go home with those therapies to do at home.
The next question is, can you talk a little bit about the beverages and amounts or times and how they contribute to incontinence, especially through the night?
Sure. So number one, the idea that we all need to be drinking 8 ounces of water a day, is incorrect. Now, for those patients who've had kidney transplants or have cardiac abnormalities and so forth, I'm not talking about that. I'm talking about your run-of-the-mill, no significant past medical history individual does not require 8 ounces of water a day. That was a number that was made up through vague physiology calculations in the 60s, just like our food pyramid. You just made it up. Typically speaking, people need about half of that. And when I say fluids, I mean water. Water is better than anything else out there, okay? And typically sipping water over the course of the day is better than glugging it. You know, oh, it's lunchtime, I haven't had anything to drink, I'm gonna drink 2 glasses of water. Well, ins equal outs. So you need to watch how you're drinking and what you're drinking. So what can cause the bladder to misbehave? Anything with caffeine. So caffeine is both a diuretic, meaning it makes more urine, and an irritant. Things like dark teas, things like coffee can irritate the bladder and cause spasticity. People at night should not be drinking. You should be hydrated during the day, and you shouldn't need anything to drink at night. And if you're drinking at night, typically it involves having a dry mouth. Well, don't hydrate the body because of a dry mouth. Treat the problem, treat the dry mouth. And the easiest way to do that is either through sugarless lozenges, sugarless gum, or biotin. And biotin comes in gels, lozenges, mouthwashes, toothpaste, you name it. One isn't better than another, but biotin is a mouth lubricant, a mouth moisturizer that can keep that fluid in the mouth. We say not to drink anything about an hour before bedtime to control that. But if that's not enough, again, that's that kind of first line therapy in the overactive bladder, then we move on to the medications.
Our next question is, would like to know the best treatment option for someone who has multiple coronary artery stents and coronary artery disease, but yet has had urinary issues for years.
Well, it depends on what those urinary issues are. Is this overactive bladder, or is this stress incontinence, or is this a combination? All of those therapies that I spoke about when it comes to the overactive bladder, from the fluid management to the physical therapy to the medications themselves to those third line options, the Botox, the PTNS, the sacral neuromodulation, all of those are options. A lot of it has to do with what has been tried, what hasn't been tried. We have to get an idea of what can work, because less is a lot of times more in these situations. So the idea is that no one is ever too old for any options. Yes, certain medical comorbidities can kind of lean us in one direction or another. But typically speaking, no one's ever too old for a midurethral sling. No one's too old for pessary. No one's too old for any of those things that I talked about earlier with the overactive bladder. But it's really tailoring therapy to the individual. That's the idea.
The next question is if you could comment more on leakage and relieving, also on incomplete relieving, full drainage but not completed, but no pains or other problems.
So that has to do with the evaluation. So part of that evaluation is, again, what I called a post-void residual. So you urinate, you believe you've emptied the bladder, and then we use this little ultrasound to determine whether you really have emptied. The vast majority of patients who feel that they are not emptying are emptying. It has to do with the fact that the bladder is spasming all the time, giving you that sensation that there's still urine there. But doc, I go to the bathroom and 15 minutes later, I can sit back down and urinate again. That's normal, okay? The bladder never completely empties, okay? There's always a little bit of urine there. Secondly, the kidneys are always making urine. So an abnormal post-void residual is a greater than 150 to 200 cc's. That's a fair bit. That's like 5 or 6 ounces of water. So typically speaking, that sense of urgency or that sense that my bladder isn't emptying is a false one. And so what we need to do is treat the spasticity of the bladder.
Our next question comes from a person who had the Mona Lisa treatments done 3 times, and she says it didn't help and was expensive. Want to know your thoughts on Mona Lisa treatments.
So the Mona Lisa, for those that don't know, is a laser therapy that was developed out of Italy. And the laser probe is placed vaginally, and the laser treatments are designed to penetrate the epithelium of the vagina at a very certain depth. And for a lack of a better description, it kind of scars the tissues, stimulating new growth and stimulating the tissues to regrow and rejuvenate. The nice thing about it is that it's non-hormonal. The nice thing about it is that it's something that typically we treat over months. So some people do it at 3 months, some people do it 6 months. The problem with the therapy is, like the person said, it's all out of pocket. It's something that doesn't necessarily have the data to really back it up. It's a newer therapy out there. There's never been a head-to-head with estrogen vaginally and the Mona Lisa. The backbone of therapy for vaginal atrophy is topical vaginal estrogen therapy. But if there are reasons why that can't be used, there are other formulations that we can use. There are medications that get broken down in the body to products that look kind of like estrogen, but shouldn't have those estrogen side effects systemically, if that makes sense. So my thoughts on the Mona Lisa, I think that it's a good option to at least have available for those patients, but it's not a first-line therapy for vaginal atrophy. But it's something that I reserve for those patients who have the money that they can spend on it to see if it works, and have potentially failed these other options.
The next person says that she tried vaginal estrogen and it felt like it caused hair loss, and want to know your thoughts on that.
So typically the concern with vaginal estrogen cream is that patients who are very atrophic and those tissues are very, very thin and sensitive, they put the cream on and it burns. Now, that's not the estrogen causing the burning. There's no woman on this earth who is allergic or has an allergy to estrogen. It's the cream, it's the ointment. Within that ointment, there are certain materials that can cause irritation, preservatives, things of that nature. So from that standpoint, patients using it, having that irritation, what we do is we have it compounded at a compounding pharmacy, the estrogen, in a hypoallergenic base. But when it comes to hair loss, the vaginal, I'm not sure if this is vaginal hair loss or systemic, vaginal estrogen therapy really shouldn't have any systemic effects. That's number one. But number two, if there are hair loss effects happening vaginally, it likely has to do more with untreated atrophy than the estrogen itself. Now, the issue with the estrogen is that it doesn't work overnight. Typically speaking, you use a pea-sized or dime-sized amount just at the opening of the vagina every night for 2 weeks, and then use it 3 days a week, Monday, Wednesday, Friday, moving forward. Most patients will notice benefits after about 1 to 2 months. It takes that long for it really to work. And if there are issues with the cream, there are also tablets, and there's also a ring that can be placed vaginally. But typically, the insurance companies will only pay for the pill or for that cream. But I don't have a good reason for hair loss. Certainly not systemically with the estrogen.
Our next comment is that comes from one who says she's 68. In the last 2 years, she's been waking up more than once during the night to pee. Other than being annoying, is this anything to worry about?
Great question. So we call that nocturia. When it comes to normal or not normal, anybody who gets up at night one or more times is considered to have this disease called nocturia. That does not mean that it's an indication for cancer, diabetes, high blood pressure, etc. The main question is whether that urgency to get up is also trickling down into the daytime. So the nighttime urgency, making sure you're not drinking, an hour before bedtime, really watching those fluid management, the fluids. Getting up once at night is, to answer the question, getting once at night is not in and of itself an indication that anything bad is going on. No.
Our next question is, does a supplement like AZO with pumpkin seed extract and soy help?
So Azo it's sort of like Kleenex or Band-Aid, okay? It's a trade name, but they've now complicated things. You go out and get a Band-Aid. There's not just a Band-Aid. There are about 30 different kinds. Same thing with Azo. So AZO used to be what's an over-the-counter version of what's called phenazopyridine, and it turned your pee bright orange. Phenazopyridine is something that we use sort of short-term, usually every 5 days, to soothe the bladder. It's a bladder salve, okay? It turns your pee bright orange. It is not a long-term therapy for lower urinary tract symptoms. It's a Band-Aid. It helps with those acute irritations that can sometimes happen when you have an infection. But that phenazopyridine is something that typically isn't great for urgency, okay? There are patients, and this is not part of this talk today, who have what's called a painful bladder or interstitial cystitis, where things like phenazopyridine can be used more long-term with some benefit. But when it comes to urgency, the typical azophenazopyridine is not a great option for really fixing the problem. Now, when it comes to pumpkin seed, vitamin C, cranberry extract tablets, soy products, all of them do different things, okay? And that's a conversation I'm happy to have with you in clinic, but each one is a little different. So soy products are an estrogen-like medication for your body. So unless you're having systemic estrogen menopausal symptoms, you don't need excess soy products. Similarly, when it comes to pumpkin seed and some of the these herbal medications that can kind of soothe the bladder, again, those aren't fixing the problem. The overactive bladder has to do with that neuromuscular connection. The bladder is spasming when it shouldn't. So we need to fix that spasticity. So if that kind of answers your question, but we can absolutely have another conversation about all of these other kind of bladder products out there.
Our next person says that her problem is leaking after urinating. Otherwise not a problem, but always after urinating, and even specifically after sitting longer, and they leak afterwards.
Mm-hmm.
The test
So
for
we call
UTI,
that post, yeah. Oh, sorry, I
test for
started
UTI
early,
was
sorry.
negative, 6 years old, 20 pounds overweight on BP meds. And she doesn't know if that's
okay. Yeah, so
applicable.
we call that post-void dribbling. And the big thing is a vaginal exam. There are certain, there's something called a urethral diverticulum that can cause those sorts of things. There are urethral masses that can sometimes cause those things. If you had prior surgery, it can kind of cause those things. But if it's not any of those, what we typically talk about is what's called double voiding. So the natural physiology of the bladder is it contracts to get rid of the urine, and then it relaxes. But then about 3 to 5 minutes later, it can contract again. So what some people need to do is they go to the bathroom, empty the bladder, stand up, wash their hands, do their thing, sit back down on the toilet and empty a second time, that double voiding. And that's perfectly natural, it's totally fine, and that can kind of help get rid of some of the dribbling concerns. But the main thing with the dribbling is making sure that any of these other things aren't going on through an exam.
Does chronic kidney disease increase incontinence?
Great question. So the kidneys typically aren't related to the bladder. So the bladder has two reasons, raison d'etre. They have two reasons of being. The bladder is supposed to store urine, relax, 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 fill, and empty. That's it, okay? So the kidneys, which are up kind of underneath your ribs here, have these little tubes that go down to the bladder, and those little ureters are constantly putting urine into the bladder. So whether your kidneys are producing urine or producing too much urine, etc., that doesn't have really anything to do with the bladder. So the bladder is either spasming, it's too relaxed, it can't empty, but kidney disease in and of itself does not affect the bladder.
Our next question is, she says she's 40 years old and wants to know if it is incontinence to drop 2 to 4 drops when you feel like going to the bathroom.
So by definition, urinary incontinence is the loss of urine when you don't want to lose urine, okay? So any kind of urinary leakage is considered incontinence. Now, normal versus non-normal, we have all of our definitions, but the main question is quality of life. So if this is an issue that affects your quality of life, then let's do something about it. But if it's, I sit down, I urinate, I think I'm done, as I stand up, I dribble a little bit more, but I don't need to change my underwear, I'm not wet, it doesn't really affect, then we're okay. We don't need to necessarily do anything. But if this is affecting the quality of life, then it's something that we should talk about and something that we can do something about.
We have a lot more questions, but we're running out of time. So just wanted to make the comment that this will be recorded live and will be posted on our website for more information on how to reach Dr. Henderson. Dr. Henderson, if people are out there having issues but are concerned about coming into a hospital or doctor's office right now, can you tell a little bit about some of the safety precautions that are happening to make sure that people aren't delaying care that should be needed, along with virtual visits too?
So first and foremost, medical concerns, please contact your doctors, okay? All of us white coats are a phone call away. And what we have been doing, we as a university hospital system have gone completely telemedicine over the end of March and April. So for me, anybody who makes an appointment with me is asked whether they would like to come in or whether they would prefer the visit happen over telemedicine. And telemedicine is one of two things. It's either a video chat, so through your smartphone or through your computer or iPad, I send you this little link, either sent to the phone number or the email or wherever you want. You click on it and there I am and there you are and we have a conversation. You can also talk by telephone, but if necessary, patients need to be seen. Hands need to be laid on. And what we're doing here at the hospitals now is screening all patients coming into the hospital with a temperature, screening questions, patients that don't have masks are given masks and gloves. Everybody is 6 feet away. We're doing, in all of my offices, we have a minimal number of patients waiting in the waiting room, at least 6 feet apart. And then after every encounter, the entire room is scrubbed down with fluoroseptic materials and so forth. I wear a mask, you wear a mask, but sometimes we need to lay some hands on. The truth is that the hospitals are one of the safest places to be right now. But the main thing is we have great options where you don't have to come in. And if we need to get some lab values, need to do some things like that, we organize it. So if we need to talk on the telephone or talk on the computer, we'll decide what needs to be done, and we'll get it organized accordingly. But it's really whatever you're comfortable with. These are strange times. I understand. I have a family. I'm sure you all want to stay as safe as possible. So whatever you're comfortable with, we can make it happen. We're trying to be as flexible as we can.
Again, thank you everyone for coming. I suggest you reach out to Dr. Henderson. There's a phone number on the screen if you'd like to set up an appointment, talk with him further, or you'll again be receiving an email with more follow-up information. Dr. Henderson, any closing comments?
No, thank you all for coming. This is one of, I love educating about this because this is such a significant quality of life issue. And after patients get treated for this, always you feel like $1 million. It turns out that sleep is important. Being able, well, once this COVID epidemic is over, being able to go outside without needing to know where all those bathrooms are. We have good, safe options, and just knowing what your options are. I'm not a pill pusher or a surgery pusher. If you don't want to do anything, don't do anything, but know your options. That's the important part.
Thank you for your talk today, Dr. Henderson, and thank you for everyone for attending. We hope you attend further health talks, and you can find those on the UH website. Thank you very much.
Thank you so much.